So first of all, we're going to talk about cardiovascular conduction. And this is just kind of a quick review for the visual learners. The sinus node or sinoatrial node is where the conduction begins. It goes down through the conduction pathway through the AV node where it slows down, and then it goes out through the bundle branches to the Purkinje fibers at the end of the conduction pathway. So the normal conduction begins with the sinoatrial node, and that has an intrinsic rate of 60 to 100 beats per minute. So that's your normal heart rate for an adult. I don't talk PD, it's a whole other section. So what is the other name for the sinoatrial node? What's its kind of nickname? The pacemaker, the chief pacemaker of the heart. So then the conduction travels down through the AV node where it is slowed down, the atrioventricular node, and the AV node has an intrinsic rate of 40 to 60 beats per minute. So that means if there's a problem where the SA node isn't firing at all, the AV node can pick up the slack and get the beats going for 40 to 60. So 60 beats per minute is kind of an ideal, what we would want to see it at. So the patient's not going to be able to go very long with 40 beats per minute, but it's not the emergency that we would be concerned about. But we do need to deal with any problems where that heart rate gets down below 60 beats per minute. So then it moves through the bundle of His into the left and right bundle branches, and it terminates in the Purkinje fibers. Now the Purkinje fibers have an intrinsic rate of 20 to 40 beats per minute. So if we have a complete breakdown of that conduction pathway, and the SA node's not working, the AV node's not working, or if they're working but we have what's called a complete heart block that we're going to talk about later, where there's no communication between the atria and the ventricles, then the Purkinje fibers can cause the ventricles to beat, but only at 20 to 40 beats per minute. So we got a real problem on this, because it's not really compatible with good cardiac output and life in general to have your heart only beating 20 to 40 beats per minute. But it's not. It's kind of there as the stopgap, but you've got to do something about it because the patient can't sustain that heart rate for a very long time. Then we have the concept of automaticity. Who can tell me what automaticity means as it relates to cardiac? Yes? Right. So all the heart cells have the ability of automaticity, which means that they can generate a beat. They can generate an electrical impulse that can cause the atria or the ventricles to contract. But only those cells that are along that conduction pathway are supposed to do that. So if you have some cells outside of that conduction pathway that are having an automaticity party, they want to join it, and they're not supposed to, maybe they're underage or something, so they start beating, and that's what's called an ectopic beat. Just like when you talked about ectopic pregnancies, pregnancies that start to grow outside of the uterus, these are ectopic beats, heartbeats generated by cells that are outside of that conduction pathway. So some of the dysrhythmias that we're going to talk about are going to be issues with some cells having automaticity and stimulating beats when they shouldn't be. So we have that electrical activity, we have that conduction of the impulse down through the conduction pathway, and as long as there's no disruption in that pathway, then we're going to have good rhythm, good contractility, good cardiac output. Anytime we have a disruption in that pathway, then we have to address the issue because it can affect the patient's cardiac output and can create some symptoms. So when we get into the specific dysrhythmias, we're really going to be focusing on what are some of the reasons why a patient has this particular dysrhythmia, what they're going to be feeling like when they have this dysrhythmia, and what are we going to do to treat it. That's our focus. That's what you need to know. If the visual part of it, really, you're really interested in it, and you like doing rhythm strips, or if, I have a student in the evening class that actually works as a monitor tech. So, this was just like, preaching to the choir to her last night. She could probably teach the class better than I can. But what we're focusing on is not the strip, but what the patient's feeling and what we're going to do about it, and what some of the causes are. So each heartbeat is one cardiac cycle. So the first part of that cardiac cycle is the contraction, otherwise known as systole, otherwise known as depolarization of the atria and the ventricles. And the other half of the cardiac cycle is the relaxation, diastole, or a repolarization. So it's always really easy for me to remember relaxation, repolarization when I try to get that whole thing. And then what the EKG does is it records those electrical impulses that are generated by that depolarization and repolarization of those cardiac cells as the atria and ventricles contract and relax. That's essentially what that EKG is measuring. So what are some types of EKG monitoring that you might see that they talked about in Pellico? 12 lead, which gives a really thorough analysis of what's going on with the heart because it's looking at it from 12 different angles. What are some other kinds that you might be more familiar with in your clinical? 5 lead or a 6 lead, a telemetry type of monitoring. So what does that consist of? When a patient's on telemetry, what do you see as the nurse taking care of them? They have the leads, 5 leads, and they have what? They have a box, a transmitter that transmits the signal to wherever it's being monitored. If you're on a telemetry unit, the monitors are probably right there at the nurse's station. In some of the smaller hospitals, like in Johnson, they're monitored in the ICU. That's where that patient who has dysrhythmias is going to be continuously monitored so that if something happens, the monitor tech can notify the nurse and the nurse can do whatever the intervention is that's been ordered. Patients who are being worked up for various cardiac diseases and dysrhythmias can wear an ambulatory EKG. What's that called? A Holter monitor. And they usually wear that for about 24 hours. And then the doctor's office downloads all the information, and they can see if you've had different times of dysrhythmias and what time of day that happened. So when I was having issues that I'll explain in more detail with PVCs back a couple of years ago, and I had to wear a Holter monitor, one of the time that I was wearing it was on a Wednesday. So I had a Wednesday evening class, and we had an exam, and we had a rather spirited exam review. So when I handed in my my Holter monitor the next day, they had some questions for me about what was going on Wednesday night, and you know, they had a few laughs about how the exam review was. So Holter monitors your patients may have. Now, when you see the strip and the grid that you're going to see for your EKG, you're going to see a dark box enclosing the smaller boxes. So each dark outlined box, which you see there, is the equivalent of 0.2 seconds, 0.2 of a second. And each of those little small boxes is the equivalent of 0.04 seconds, so 4/100ths of a second. And that's going to be important when you're that nurse or that monitor tech or that telemetry nurse measuring and finding out what the patient's heart rate is based on the number of small boxes or large boxes there are. And we're going to talk about that method of calculating heart rate. This, because I'm a horrible artist, I finally decided to just put the picture up because I used to draw the EKG and it was really pathetic. So this is a much better representation of what you're going to see and what the different parts of the EKG stand for. Again, you're not going to have to identify the strip, but if I tell you, or you tell me actually, what does the P wave stand for? What does that represent? Atrial contraction. So if you're looking at an EKG and you see a weird looking P wave, what is your conclusion going to be? Something wrong with the atria. The QRS indicates what? Ventricular contraction. So if there's an aberration in the QRS, then you can assume, you can critically think your way through, that there's problems with the ventricles, right? Now the P to R interval goes from the beginning of the P wave to the beginning of the QRS, and that tells you that length of time that it takes the impulse to travel from the sinoatrial node down through the AV node, because it is slowed down. So there's a certain period of time that normally it will take to go from the atria into the AV node and then cause the ventricles to contract. And that's usually about 0.12 to 0.2 seconds. So if you see a shortening or a lengthening of that P to R interval, what is that going to tell you? Say it's a lengthening, which you'll be seeing very commonly. Right, it's slowing down too much as the impulse passes from the atria to the ventricles. So that way, if you looked at that and you said, wow, I've got a really elongated P to R interval, that's telling me that the impulse is slowing down too much, and now we're going to have some problems. So that's essentially really what you need to know about these waves to kind of help you look at that and say, okay, I've got a problem or I don't. The T wave is telling you what? It's the relaxation of the ventricles. Also, the atria are relaxing during that time period, but you can't see the actual impulse from that because it's kind of overshadowed by the stronger impulse that you get from the ventricles. But everything's relaxing as they're so you're in diastole in the T wave. What happens? What did we talk about last week that occurs during diastole? The ventricles, the cardiac chambers fill, and what else? It's really important. The myocardium is being perfused from the coronary arteries during diastole. So if you have a tachydysrhythmia, where you've got a shortened T wave, a shortened ST segment, less time between beats, that's less time for those chambers to fill and less oxygenated blood that's getting to the coronary arteries. So that's going to reflect what's happening and what some of the symptoms are that your patients are having when they have, for instance, tachydysrhythmias. So then interpreting EKGs. There's different ways of determining the heart rate. I'm not going to specifically test you on these, but just when you're looking at the grid, the EKG strip, the most common one is they either use the large box or the small box method. So who can tell me what the large box method is? Mm-hmm. Right. So you either go, and let me go back to the picture. You either count the number of large boxes between two R waves, because that's every QRS complex indicates one beat. So you can count the number of large boxes between the two R waves or between the two P waves. So from here, say, to here. And then what do? You divide by 300, divide into 300. And that will give you your beats per minute. Beg your pardon? Yes, Kelly? By the number, yeah. So it's 300 divided by the number of large boxes between the two R waves or the two P waves. If you have this, if you use the small box, you're going to count the number of small boxes between the two R waves or the two P waves and divide that into 1,500. And or you can look at Sarah. Did you have a one? Oh yeah, I know, but that's cheating. Yeah, the strip is going to tell you what the heart rate is. But you know, I mean, if you want to show, if you want to show off a little bit, you can get there and actually, hide that and try to see and really just for practice, if you decide you're really into this and you want to, you want to learn how to do this, cover up what it says and see if you can calculate the same heart rate based on the rhythm strip. Or on that strip, you'll see 3-second markers. And if you count the number of R's or P's between the two 3-second markers and multiply by 10, you've got 60 seconds. So calculating heart rate. Yeah, you either read what's on the top of the strip or on the report, or you can do that method. Determine regularity. That's where those calipers come in that you'll see the nurses using. And what you're going to do is measure the difference between the two R waves, and then go to the next and see if the caliper shows that you're not changing the measurements and the adjustment of the caliper, because that will determine whether or not you have regular heart rates. So if you have a narrow gap and then a larger gap and you're going back and forth, then you've got an irregular heart rate. If the interval is the same, then you're all set. You're going to determine if it originates from the SA node. Now, how do you think you would do that? What would you look at on the EKG? The P wave. The P wave looks normal, and all the P waves look normal, then you know that the impulses are originating normally from the SA node. You're going to evaluate the conduction. And that's where you're going to look at that P to R interval to see if it's longer in some cardiac cycles, shorter, or if it's always longer than it should be, and determine whether or not you're getting good conduction and it's conducting properly down through that system. And then you're going to look at the appearance of the EKG. Does it look normal? And if it looks abnormal, then in your experience, what does it look like that you've seen from an abnormal rate? So does that look like a PAC that you've seen before? Does that look like a PVC that you've seen before? So all those are going to help you interpret what's going on with the patient. Or you can just read that little strip across the top that tells you that the patient's in AFib and the heart rate is 150. Yes, Kelly? What's that? Well, if you're looking at, I mean, all the P waves should look somewhat like this, and they should all look alike. And when we get into some of the atrial dysrhythmias, you'll definitely see where the P wave looks abnormal. So now we're going to start with our, yes? Did I miss a slide? I don't know. Whoops, I'm sorry, what? I did that, and I did that one, right? And now we're going into this. Okay. So now it's time to pull out your handout, and we're going to look at this dysrhythmia tape, CD-ROM, which is really kind of cool because I can put the sinus rhythm on top, and that's what sinus rhythm looks like. And then I can start doing some comparisons of some of the other dysrhythmias. So the first thing we're going to talk about is normal sinus rhythm. And you're going to know that it's normal sinus rhythm because all of your P waves look the same. So here's a P wave, and a P wave, and a P wave, and they all look the same. And then you look at your QRS, and they all look the same. And you look at your T, and they all look the same. And you have equal distances between your R to R, so it's a regular rate. And in this case, it's a sinus rhythm at 70 beats per minute. So normal sinus rhythm is going to be anything between 60 and 100, where everything is regular and all the waveforms look the same as they go through each cardiac cycle. So basically, what are we going to do for that patient who is in normal sinus rhythm? Absolutely nothing. Now, we can also have a condition that is called sinus arrhythmia. And actually, I'm going to put that on top and keep the sinus rhythm on the bottom. Now, sinus arrhythmia, all that means is that the heart rate speeds up when they take a breath and slows down when they exhale. So they have an arrhythmia, they have an irregular heart rate, but it's totally benign and it only changes in response to breathing in and out. Some elderly patients may have it, some young patients may have it. They're totally asymptomatic, and there's really nothing that you're going to do for that. But you may see that. I had a doctor pull us over to the patient one time and said, I hear sinus arrhythmia, and then the patient started panicking, and we said, you know, don't worry about it, don't worry about it, it's cool. So we grabbed my student and we listened, and it was very, very pronounced that every time she breathed in, the heart rate got faster. Every time she exhaled, the heart rate slowed down. So not a problem. So you can see that up here. You can see that we've got the PQRST. You've got this normal length between there, and now all of a sudden it's a little bit shorter in between the complexes. Then it's longer and longer. And if I start it up and then I freeze it, we've got normal, and then now this is when she probably took some breaths in and it got a little bit slow. It got a little bit faster. So it's an irregular rhythm, but not one that you have to worry about. Now, the next thing we're going to talk about is sinus tachycardia, and I'm going to put it up there at 160 beats per minute. So you got sinus tach on top, sinus rhythm on the bottom. So Sinus tach is going to be a heart rate greater than 100. So anytime you have a heart rate greater than 100, it's tachycardia. And then for this particular case with sinus tachycardia, it's still regular, and the P, Q, R, S, T waves all look the same and they all look normal. It's just a rapid heart rate. So if you look at this, you'll see the P wave right there, the QRS, the T, they all look alike. It's just a faster heart rate. And usually what happens with sinus tachycardia is that it's not a problem with the SA node itself malfunctioning. It's usually some underlying cause that makes your heart rate go faster. So what are some of the causes that can make your heart rate go faster? Yes? Fevers. Dehydration. Drugs. Certain drugs can do that. So again, not a problem with the SA node usually. It's an underlying problem. So we have to correct that underlying cause. And sometimes we can correct it with medications. So calcium channel blockers, because what did we learn about calcium channel blockers? What do they do? Slows down the heart rate. Beta blockers slow down the heart rate. Or we can give a medication called adenosine, which, as it says on your handout, causes a short period of asystole, and that's, of course, that's the best case scenario, a short phase of asystole, and then it resets into normal sinus rhythm. So where do you think you might have to have that patient if you're giving them adenosine? In the ICU with a crash cart nearby. Now, Jan told kind of a funny story about adenosine when her dad had to have it in the ambulance for SVT that we're going to talk about in a second. And she said he was totally conscious and talking to her while it was flatline on the monitor. You know, and she's going, "Dad, are you feeling okay?" And he goes, "Yeah, it's fine." And she's looking at the monitor. And they're waiting for it to kick back in, and finally he kicked back into normal sinus. So that is sinus tachycardia. Now we're going to talk about sinus Brady, and I'm going to put up 40 beats per minute so you can really see the difference. So bradycardia is a heart rate less than 60. And just like sinus tach, it's frequently not a problem with the SA node itself, but some underlying cause that's making your heart rate go slower than 60. So what are some of the reasons why you have a heart rate less than 60? What's that? Hypovolemia? Well, no, that would more be a tachycardia because the body's trying to compensate for lack of oxygen. What's that? Hypothermia? A normal athletic heart. There are some people that will have a heart rate in the 50s, and that's their baseline. Vasovagal reactions can do that to you. And so for sinus tach, sometimes having them do a vasovagal action can take them out of sinus tach. But patients can become bradycardic because of an MI, DIG toxicity, increased intracranial pressure. So you know it's sinus Brady, other than some other Brady dysrhythmias that we're going to talk about, because the P, Q, R, S, T are all normal looking. And there's equal distance between all of the complexes. It's just that they're farther apart. Now, if we have either a tachydysrhythmia or a Brady dysrhythmia, both of those are going to affect cardiac output. Why? How's the tachydysrhythmia going to affect cardiac output? Right, you're shorting diastole, you're not getting enough filling, so there's less cardiac output. How about bradycardia? Right, because the cardiac output is the amount ejected within 1 minute. So you could have good contraction and you could have a good regular rhythm, but if you're not getting enough beats per minute, then that's going to affect your cardiac output. So everything is looking normal, but it's less than 60. So if they're symptomatic, and we try to correct that underlying cause. If they're symptomatic, we need to instruct them to avoid the Valsalva maneuver, because that's going to make it worse. I mean, if they're asymptomatic, I'm sorry. If they're symptomatic, we may need to give atropine, because what does atropine do? It raises the heart rate. So if we can't, by treating the underlying cause, get them back up to a normal sinus rhythm, then atropine would be our treatment for that patient in bradycardia. So now we're going to start talking about things that can happen, dysrhythmias and dysfunctions of the atrial conduction. So I am going to put PACs on top and normal sinus rhythm on the bottom. So PACs occur when you have an area of irritable focus in the atria that causes an extra beat. And it doesn't happen like continually, it happens intermittently, usually. And there's usually an underlying problem. The most common problem for patients who have PACs is stress or too much caffeine. So that kind of covers all of you in the class. And I have had a number of students who have raised their hands during this part of the lecture and said, that's what they told me I had was PACs. And some patients won't know that they're having them, and other patients may feel a fluttery feeling, or they may feel their heart skipping a beat. And what you're going to see is you've got here the normal P wave, a normal P wave, a normal P wave, and then on this, as it's coming down from the T, you see that little blip on the T wave and then a little teeny weeny P wave there. That's a PAC. And then what happens is there's usually a pause after that. So the heartbeat will be irregular. And the patient will feel sometimes a drop in cardiac output. They may, like I said, they may feel a little lightheaded. They may feel fluttery if it happens frequently. So again, we have to treat the underlying cause. So with most patients, including nursing students, we say cut back on the caffeine, get some more sleep, reduce your stress, and then we realize that, we're just basically talking to a brick wall for you guys. We can give DIG or quinidine, which is a dysrhythmic. But usually stress, caffeine, cutting down on those will help. Some patients may always have PACs, they don't even know they're having them, and they're totally asymptomatic. It just maybe comes up when they're getting checked for, for surgery or some other routine EKG. So those are PACs. One area of irritable focus in the atria causing an extra beat occasionally. It's not from the SA node. It's again, it's some automaticity that's happening outside of that conduction pathway. It's an ectopic beat. Now, if you have a lot of PACs, it can put that patient into SVT, and I'm trying to find it. Oh, there it is. Okay, SVT, supraventricular tachycardia. Supra meaning above. So it's a tachycardia that happens, that is occurring and being caused by something that's happening above the ventricles. They can also have what is called PSVT, paroxysmal SVT, where they're having bursts of this phenomenon. So we're having a regular rhythm in the supraventricular tachycardia. It originates above the ventricles, and the rate is usually 150 or greater. You can get this, strangely enough, with DIG toxicity, which is odd because you would think the patient would be extremely bradycardic. But sometimes patients with DIG toxicity will end up with SVT. Yep. DIG can cause a lot of strange things. Acidosis, alkalosis, ischemia. And usually what's happening is those ectopic beats are happening in the SA node, in the atria, in the atrial conduction pathways. So everything is happening up above the ventricles. And the impulses keep circulating back to the atria, and that's why we have this rapid heart rate. And we're having normal conduction through the AV node. So our conduction through and down to the ventricles is normal, but oftentimes the heart rate is so fast you may not even see the P wave. So here you're looking at that little tiny blip there is your P wave. And then QRS and kind of a big T there, and that little tiny notch is your P wave. It's going so fast you're barely seeing your P wave. And these patients, if you have sustained SVT, are going to start feeling things like maybe chest pain if they have some perfusion issues. They're going to feel palpitations. They're definitely going to be, most patients are going to be very symptomatic with SVT. And some of the treatments, and you look at on your handout, Valsalva maneuver, ice water to the face, which basically shocks the patient, adenosine, calcium channel blockers, carotid sinus massage. Again, you have to have the crash cart by, because you could, if you do that, because you have to do both, and that can cause the patient to pass out. And in some cases, cardioversion, which we're going to talk about in more detail a little bit later. Patients who have a chronic history of SVT are going to be on oral antidysrhythmics for long term, things like a beta blocker or amiodarone. So that is SVT. We're having a lot of PACs, and there's the ectopic beats are circulating back into the atria and causing this very rapid atrial rate, and then the ventricles, because the ventricles want to keep up with the atria. So the ventricles are going to start pumping, and that's where you're getting that really rapid heart rate. So we all set with those so far? Okay, now we're going to talk about, and in your handout it talks about atrial flutter and atrial fib, and the concept of atrial kick. The fact is that when you have, when the atria contract, a certain percentage of their blood is going to be pushed into the ventricles by that contraction of the atria. That's atrial kick. The rest of the blood from the atria flows passively down into the ventricles by gravity. So if you have a problem where you've lost atrial kick, where the atria aren't contracting efficiently, then blood is pooling in the atria and causing clots. And so patients can have these atrial dysrhythmias, atrial flutter and atrial fib, as a chronic condition, or they can go in and out of these types of conditions. So oftentimes the patients that have a chronic atrial fib, if we control it with the primary med would be DIG, they may be totally asymptomatic. Other patients may go in and out of these dysrhythmias, either a flutter or a fib, and be very symptomatic and have extremely rapid heart rates that need to be reversed and need to be corrected. So the first one we're going to talk about is atrial flutter. And I'm going to put that on top. Now what's happening in atrial flutter is that one ectopic focus in the atria is firing very, very rapidly and repeatedly. And because you're just having that one area of focus and you have contraction of the atria, you're going to see a P wave. You're going to see a sawtooth P wave, but you're going to see those markings, that sawtooth marking that shows that there is some contraction of the atria in atrial flutter. And usually when they're in atrial flutter, it's like a 3-to-1 ratio. They have 3 contractions of the atria and then 1 ventricular contraction. So with atrial flutter, you're going to see a sawtoothed P wave, which means that the atria are still contracting. So we're getting some atrial kick. We're getting some contraction of the atria where some of the blood is going down into the ventricles, but it's going to be diminished because of the rapidity of that contraction. So we haven't lost all of our atrial kick, but we're losing some of it. We're not getting as much. And blood is going to pool in the atria. So we're going to have some issues with clotting. And to get that patient out of atrial flutter, we're going to give those meds that slow down the heart rate. So our beta blockers, our calcium channel blockers, DIG. And then if we can't get them out of atrial flutter and they're symptomatic and it's an issue, then we need to do cardioversion, which we'll talk about in a little bit. Or we can do ablation, where radiofrequency waves are zapping those areas of ectopic beats, those areas where they're having that automaticity party, and they're going to shut it down. They kill those cells, and then and that will help that heart go back to a normal rhythm. Now, prior to doing cardioversion, they're probably going to do a TEE, a transesophageal echo. Why would they do that? Well, what do they need to find out before they cardiovert that patient back into normal sinus rhythm? If there's any clots in the atria. Because if there's clots in the atria, and that patient in AFib or A-flutter, and you cardiovert them back into normal sinus rhythm, and now all of a sudden the atria contract the way they're supposed to, bada bing, we got a clot that goes up to the, usually up to the brain and causes a stroke, or it can go and cause a pulmonary embolus. So a TEE prior to cardioversion.
So for this one, since the atria is
Contracting, yeah.
there's also not complete empty.
Right, right, right. No, what's happening is that you have some atrial kick, but not sufficient to get everything that it's supposed to get pumped by the atria, and then you have the passive filling of the rest of the atrial content, so some of it is going to pool in there. Now you're going to have it a lot worse when you talk about AFib. So I'm putting atrial flutter on the bottom, and I'm putting atrial fib on the top. So what do you see that's different about the P waves? Right, you're not getting any atrial contraction when you have atrial fib. So all you've got is like a squiggly line. So you've got no P waves. So here you've had a total loss of atrial kick because there's no atrial contraction. So atrial flutter has the sawtooth P waves. Atrial fib has the squiggles. It's fibrillating, it's quivering. And when the chambers quiver, they can't contract and they're not pumping anything out. So the same kinds of treatments for AFib that we did for A-flutter. So everybody see the difference? Fibrillating, quivering, no output. Flutter, still contracting, but it's really fast, so it's a little bit less output than what they should have. Still getting the passive filling, but you've lost the atrial kick, so you're getting blood pooling and forming clots. More than what you would see with atrial flutter, but it's still a risk for both conditions. So those are the atrial dysrhythmias, and we're going to take a 10-minute break, and then we'll get into the ventricular dysrhythmias, because I can see that I'm losing you.